You hear the phrase kidney stone, and you immediately think of one thing, right?
Oh, sheer, unadulterated agony.
Exactly. I mean, we've all heard the horror stories from a friend or a coworker. People literally say it's worse than childbirth.
Yeah, I've heard that comparison a lot, actually.
But what's truly wild to me is that the pain is really just the very end of a story. It's a story that is quietly unfolding inside the body for months or sometimes even years before you ever feel a single thing.
Right, it's completely silent until it isn't.
Exactly. So our mission for this deep dive, and we're pulling from this massive stack of historical texts, urology case studies, and even, surprisingly, modern climate research.
Yeah, the climate angle is fascinating.
It really is. But our goal for you today is to look past that visceral horror. We're going to unpack this surprisingly complex pathophysiology, the bizarre chemistry, and the historical mysteries of how these crystalline masses actually form.
And why they hurt so much.
Right. And also why everything we used to think about preventing them was completely dangerously wrong.
It really is a fascinating contradiction to explore. You have this acute, chaotic, terrifying medical emergency that is ultimately born from very slow, very precise laws of microscopic chemistry and fluid dynamics.
Yeah, like geology happening inside your organs.
Pretty much. I mean, it's a condition that has plagued humanity since antiquity, yet researchers are still actively debating the granular details of how the plumbing actually fails.
Okay, let's unpack this. At the most basic level, before we get to the agonizing pain, what exactly is a kidney stone? I think most of us listening just picture like a jagged little rock that somehow gets swallowed up by our internal organs.
Right, which isn't exactly how it works.
So biologically, what are we dealing with here?
Well, medically, a kidney stone is termed a renal calculus, or if you were looking at the broader disease state, it's called nephrolithiasis.
Nephrolithiasis, got it.
Simply put, I mean, it is a hard crystalline mass. It forms inside the kidney when substances that are normally dissolved perfectly in your urine, things like calcium, oxalate, phosphate, or uric acid.
Basically the waste products, right?
Yeah. Exactly, the waste products. They become so highly concentrated that they physically precipitate out of the liquid solution. They aggregate, they clump together, and they form a solid architectural structure.
How big are we talking?
Well, they can range in size from like a microscopic speck of sand that you pass while barely noticing, all the way up to what clinicians call a staghorn calculus.
A staghorn calculus. That sounds intense.
It is. That is a massive branching stone that essentially casts a hard, concrete-like mold of the entire inside of the kidney.
Oh, wow. That is terrifying.
Yeah, it's not great.
But, it sounds so tidy when you describe it like that, just substances precipitating out of a liquid. But reading through our sources, it becomes clear that before a stone can even cause a problem, it has to originate somewhere, right?
Right, it needs a starting point.
And that exact origin point seems to be the subject of a massive scientific debate. If we start at the spark, how does this actually begin?
So the foundational principle we have to understand is a chemical state called supersaturation. I mean, urine is not pure water. Right. It is a highly complex solution carrying a very specific, heavy load of dissolved waste products.
Which makes sense because every liquid solution has a saturation point. I was thinking about this, and it's exactly like making iced tea, right?
Oh, yeah, that's a perfect analogy.
Like if you add a spoonful of sugar to cold tea, it dissolves. You add a second spoon, it dissolves. But eventually, if you keep pouring sugar into that cold tea, it hits a physical limit.
The water molecules are completely occupied.
Exactly. The liquid physically cannot hold any more dissolved sugar, and the excess just crystallizes and settles in this crunchy pile at the bottom of the glass.
That is exactly what happens in your body. The kidney is essentially a master bartender trying to keep all that sugar dissolved, but it only has so much water to work with.
So supersaturation is the initial spark.
Yes. Your urine becomes supersaturated if your kidneys are conserving too much water, like when you are chronically dehydrated. The liquid volume drops, but the waste volume stays the same.
Or I guess if the waste volume goes up.
Right. Or it happens if the solute load itself is unusually high, perhaps from a diet exceptionally heavy in animal protein. But this creates a massive anatomical puzzle.
How so?
Well, once those microscopic crystals nucleate and form in the kidney fluid, where do they go? Because for most of the 20th century, the dominant medical model was the free particle theory.
The free particle theory. So they just float around.
That was the idea. The idea was that a crystal just forms somewhere in the middle of the fluid, floats along in the urine stream, and either washes out harmlessly or, randomly gets stuck in a narrow tube and grows.
But wait, why don't they just wash out with the urine before they get big enough to matter? I mean, it seems like if they are floating freely in a river of fluid, they'd just be flushed away long before they become a jagged rock.
That is exactly what researchers asked, and they actually ran the complex fluid dynamics on this back in 1978.
Oh, they did the math on it.
They formalized the mathematical models, and they proved that a free-floating crystal would have to grow at an impossibly fast, almost magical rate to reach a clinical size before the sheer physical flow of urine washed it right out of the kidney.
So the math just didn't work.
The math simply did not support the free-floating theory. These stones needed an anchor. They couldn't just float. They had to attach to the wall.
See, here's where it gets really interesting. Because the biological proof for that anchor actually existed decades earlier, but people just hadn't fully connected the dots.
Right, the 1930s research.
Yeah, I was looking at the research from 1937 by this urologist named Alexander Randall. He wasn't satisfied with the vague idea of stones just floating in concentrated urine.
He wanted physical proof.
Exactly. So he went straight to the morgue. He examined over 1,000 autopsy kidneys.
Which is just a staggering amount of rigorous manual pathology.
It's incredible. And what Randall found in the tissue was revolutionary. In roughly 1 in 5 of those kidneys, he found small, white, calcified deposits embedded right on the tips of the renal papillae.
And for those listening, the papillae are essentially the tiny biological funnels where the kidney empties newly made urine into the body's collecting system.
Right, like the drainage pipes. So he proposed that these localized deposits, which we now literally call Randall's plaques in his honor act, as the anchor point.
Exactly. A stone doesn't just spontaneously form in the middle of the fluid. It builds outward onto this fixed, calcified plaque that has eroded through the tissue to touch the urine.
It just sits there.
It sits there, anchored to the wall, slowly accreting new layers of crystal over months or, years.
And what's absolutely amazing to me is that Randall had to use dead tissue and a scalpel to figure this out in the 1930s.
Oh.
But fast forward decades later, and modern researchers use high-definition digital endoscopy to actually photograph the insides of living patients' kidneys during surgery.
The Williams and Evans studies.
Yes, and they visually confirmed it. They literally saw stones physically attached to these white plaques in the majority of patients forming common calcium stones.
It's a beautiful confirmation of a hypothesis made nearly a century prior. Stone is quite literally growing on the wall of the kidney, safe from the rushing current of the urine.
So if we've established how they start, we have our supersaturation spark, and we have our Randall's plaque anchor holding the stone to the wall of the kidney. If it's securely anchored in there, why is it so notoriously painful?
So this is the physiological detail that trips up almost everyone outside of the medical field. A stone merely existing in the kidney usually causes absolutely zero pain.
Wait, seriously?
Seriously.
So if you're listening to this right now, you could just have a rock hanging out in your kidney and have no idea.
Many people do. They are frequently found incidentally when a patient gets a CT scan for a completely unrelated issue, like a suspected appendix problem or something.
That is crazy.
It is, but it's because the functioning fleshy tissue of the kidney, the parenchyma, actually contains very few pain-sensing nerve fibers.
So if the rock itself sitting in the kidney doesn't hurt, what triggers the sheer agony people talk about?
Obstruction.
Oh.
The excruciating pain, what clinicians term renal colic, only begins if that stone breaks off from its plaque anchor, travels out of the kidney, and enters the ureter.
And the ureter is the tube.
Right. It's the very narrow muscular tube that connects your kidney down to your bladder. If the stone gets wedged in that tight space, it acts like a cork in a bottle. It blocks the flow of urine.
But the kidney is still making urine.
Right. Exactly. Your kidney, which is upstream from the blockage, has no idea there is a cork in the tube. So it just keeps filtering blood and producing urine at its normal rate.
Oh, wow. So it's exactly like leaving a garden hose running full blast, but you've tightly kinked the middle of the hose. The water has nowhere to go, and the internal pressure just builds and builds.
That pressure buildup is absolutely devastating. It causes the kidney capsule to literally stretch and swell, a condition visible on imaging called hydronephrosis.
And the capsule has nerves.
Yes, the capsule surrounding the kidney is packed with nerve endings, so that stretching is intensely painful. Furthermore, in response to this physical blockage, The smooth muscle of the ureter goes into overdrive.
Like it tries to push it out.
Right. It starts having violent peristaltic spasms, contracting as hard as it can to try and squeeze the stone through. It is the exact same physiological mechanism as intense intestinal cramping when you have a bowel blockage, just, localized to the urinary tract.
That sounds horrific.
Oh, it gets worse. To make matters worse, the physical trauma to the tissue releases inflammatory chemicals called prostaglandins.
Prostaglandins, okay.
These amplify the pain signals and actually increase local blood flow, which transiently increases urine production, pumping even more fluid into a blocked system.
That sounds like an absolute nightmare. Loop pressure, spasms, and chemical inflammation all just feeding into each other. But if it's all about obstruction, the physics of passage must be crucial. I mean, does a millimeter really make a difference between passing it at home versus ending up in surgery?
A millimeter changes everything. Urologists ran massive analyses in the early 2000s, looking precisely at the physics of passage.
Like the Cole study from 2002.
Exactly. They tracked spontaneous passage rates based on the millimeter size of the stone on a CT scan. If your stone is under 5 millimeters, you have roughly a 68% chance of passing it on your own with just time and fluids.
Okay, so decent odds.
Right. But the moment that stone hits between 5 and 10 millimeters, that probability plummets to less than half.
That is a massive drop-off just from a few extra millimeters of crystallization. And while we're talking about the pain of passing it, I read about this fascinating diagnostic detail regarding where you actually feel the pain. Because it's not just in your back, right?
No, it migrates. Because the ureter and your reproductive organs, so the testicles or the ovaries, share the exact same embryonic nerve origins and spinal cord pathways from when you were developing in the womb.
Wait, really?
Yeah.
Embryonic pathways?
Yes. So the brain gets confused about where the pain signals are actually coming from. As the stone travels down the ureter, the pain classically radiates in a pattern known as loin to groin.
Loin to groin.
It starts as an ache in the flank or lower back, and it migrates agonizingly down toward the groin or genitals. Clinically, it's actually one of the most reliable diagnostic clues in all of medicine.
It is just wild that the microscopic wiring of our nervous system from when we were embryos dictates how we feel a kidney stone decades later.
It really is.
But let's move from the pain to the prevention. Because if we know it hurts, and we know it's caused by supersaturation, it seems obvious that we just need to starve the body of the minerals making the stone, right?
You would think so.
Right. If I go to the doctor and they test my stone and they tell me it is a calcium oxalate stone, the most logical, intuitive thought in the world is, okay, the stone is made of calcium, so I need to stop eating calcium.
Well, what's fascinating here is that for decades, that was the exact self-evident logic driving medical recommendations. Yes. Doctors routinely told patients to aggressively restrict their dairy and calcium intake. But it turned out to be completely dangerously wrong, and it actually made the disease much worse.
How is that even mathematically possible? If the stone is made of calcium, how does eating more of it prevent the stone? What is the underlying mechanism there?
You have to look at the entire digestive system, not just the kidney. I mean, the calcium you eat doesn't just magically teleport to your renal system, right? It processes through your gut.
Go here.
When you eat a diet with normal, healthy amounts of calcium, that calcium acts like a chemical sponge in your stomach and intestines. It binds to the oxalate that is naturally found in a lot of healthy foods, like spinach, nuts, and chocolate.
Oh, I see.
Because the calcium and oxalate bind together in your gut, they form a bulky complex that your body's intestines physically cannot absorb into the bloodstream. So you just safely excrete it in your stool.
Ah, okay. So the calcium ties up the oxalate in the digestive tract before it ever gets a chance to reach your kidneys.
Exactly. But if you restrict your dietary calcium, you remove the sponge. Suddenly, there is nothing in your gut to bind the oxalate.
And so the oxalate just goes rogue.
Pretty much. That free oxalate gets rapidly absorbed through the intestinal wall into your bloodstream, travels straight to your kidneys, and is dumped into your urine. And here is the twist. In the urine, it is actually the oxalate, not the calcium, that is usually the more dangerous limiting ingredient that triggers the supersaturation spark.
Oh, wow.
Yeah. By cutting your dietary calcium, you paradoxically spike your urinary oxalate, rocketing your stone risk upward. A massive randomized trial in 2002, the Borghi trial in the New England Journal of Medicine, definitively proved that patients eating normal amounts of calcium had significantly fewer stones than those restricting it.
So if you're listening to this and thinking, I'll just stop drinking milk or eating cheese to stop my stones, you are falling into the exact same trap that the medical establishment did for years.
Intuition can be incredibly dangerous in medicine.
It really can. And that wasn't the only major medical reversal we found in the sources. What about when the stone is already stuck? I remember seeing notes on a major trial around 2015 that tested those prostate drugs in the ER.
Ah, yes. You're referring to medical expulsive therapy, or MET.
Right.
For years, emergency rooms worldwide were routinely prescribing alpha blocker drugs, primarily tamsulosin. Now, these drugs are normally used to treat prostate enlargement by relaxing smooth muscle.
Okay, so why use it for a kidney stone?
The theoretical mechanism was beautiful. If the ureter is spasming and gripping the stone, an alpha blocker should relax the smooth muscle of the ureter, open the tube up, and let the stone slide out effortlessly.
I mean, it sounds totally logical. Relax the pipe, clear the blockage.
And small early studies suggested it worked wonders. It became unquestioned dogma in emergency departments everywhere. But then came the Suspend trial in 2015, published in The Lancet.
That was the big one.
It was a massive, rigorous, placebo-controlled study, and it proved that for the vast majority of common stones, tamsulosin offered absolutely no significant benefit over a placebo for spontaneous stone passage.
None at all.
Nope. The smooth muscle relaxation didn't overcome the physical physics of the blockage. The body's natural passage rates were doing the heavy lifting all along, not the drug.
Which brings us to an overarching realization here. We keep talking about kidney stones like it's one singular uniform disease. But the failure of generic advice like, just cut calcium or just take this muscle relaxer, reveals that not all stones are the same. A kidney stone isn't just a localized plumbing issue. It's a window into the patient's entire metabolic, genetic, and even infectious health.
That is a crucial distinction. The chemical composition of the stone dictates everything about the pathophysiology and the eventual cure.
Right.
We've talked deeply about calcium stones, which are largely driven by diet, hydration, and that supersaturation mechanism. But there are 3 other major categories of stones, and their mechanisms operate entirely differently.
Let's walk through those because this really broadens the scope of what is actually happening in the body. Take uric acid stones, for example.
So, uric acid stones aren't primarily about calcium or oxalate at all. They are intrinsically linked to an abnormally acidic urine environment.
And what causes chronically acidic urine?
Very often, the underlying mechanism is insulin resistance and metabolic syndrome. Uric acid stones are closely tied to conditions like gout and type 2 diabetes.
Oh, interesting.
But the really fascinating thing about uric acid stones is that, unlike a calcium stone, you can sometimes completely dissolve them inside the body just by prescribing medication that alkalinizes the patient's urine.
Wait, you can dissolve them?
Yeah. By raising the pH until the uric acid simply melts back into solution, you can completely avoid surgery.
That is incredible, a chemical solution to a physical blockage.
Oh.
But what about struvite stones? Because you mentioned those massive branching staghorn calculi earlier. Do those form from diet too?
Not at all. Struvite stones are an entirely different, terrifying beast. They are driven entirely by infection.
Infection. So bacteria.
Yes. They are caused by specific bacteria, most notably a bug called Proteus mirabilis. These bacteria produce a specific enzyme called urece, and this enzyme's entire job is to split urea, which is naturally abundant in urine, into ammonia.
And ammonia is highly alkaline, right?
Exactly the opposite of the uric acid problem. The ammonia rapidly alkalinizes the urine to an extreme degree. This sudden shift in pH causes magnesium ammonium phosphate crystals to precipitate out of the liquid at astonishing speeds.
And that forms the staghorn.
Right. The stone grows so fast it fills the entire internal cavity of the kidney, creating that staghorn shape. And you cannot fix a struvite stone with diet or hydration. You have to surgically extract the entire stone matrix and aggressively treat the underlying bacterial infection, or it will just grow right back.
It's basically like a bacterial construction project happening inside your organ.
Exactly.
And then you have the fourth major type, cysteine stones.
Yeah.
If struvite is infectious and uric acid is metabolic, where does cysteine come in? Is that a lifestyle issue too?
No. Cysteine stones bypass diet and infection completely. Cystinuria is a distinct inherited genetic disorder. It's a mechanical failure of the kidney's internal recycling system.
How does that work?
Think of the kidney's filtration tubes like a conveyor belt. Normally, specific genetic transporters grab valuable amino acids like cysteine off the waste conveyor belt and put them back into the bloodstream.
But in these patients, the sorting machine is broken.
Precisely. Because of a genetic defect in those specific transporters, the recycling machine fails. The cysteine stays on the conveyor belt, spills heavily into the urine, and because it is highly insoluble, it rapidly forms stones.
So how do you treat that?
It requires intensive genetic counseling and massive round-the-clock fluid intake to manage. It proves that some urolithiasis is purely a hereditary bad roll of the genetic dice.
It really is a full-body phenomenon.
Yeah.
And, it's a historically enduring one, too. Diving into the historical sources on this, I was absolutely stunned to read that archaeologists have physically found a bladder and kidney stones sitting inside the pelvises of Egyptian mummies dating all the way back to 4800 BCE.
It's incredible how long we've been dealing with this.
Right. The Hippocratic Oath, from ancient Greece like the foundational text of medicine, literally has a specific clause telling general physicians to not cut for the stone and to leave that horrific procedure to surgical specialists.
Because the historical burden of this disease is profound. Before the invention of modern non-invasive lasers and shockwave lithotripsy, the primary treatment was lithotomy.
And lithotomy means?
That meant literally cutting into the perineum, the bladder, or the kidney with primitive tools to manually extract the stone.
And they did it entirely without anesthesia. The sources detailed the story of the famous 17th century diarist Samuel Pepys. Have you heard this story?
The 1658 surgery, right?
Yes. He suffered from agonizing stones and finally elected to have a lithotomy in 1658. He was tied down, fully awake, while a surgeon cut him open to fish out a stone the size of a tennis ball.
A tennis ball without anesthesia.
Unimaginable. And incredibly, he actually survived the procedure in an era before antibiotics. He was so intensely relieved to be free of the pain that he kept the extracted, blood-stained stone in a custom display case.
Wow.
For the rest of his life, he threw a lavish dinner party every single year on the anniversary of the surgery just to celebrate the fact that he was still alive. It really puts into perspective how terrifying this ordinary condition used to be.
It really does. And if we connect this historical terror to the bigger picture of today, while we thankfully no longer face the butchery of 17th century surgery, the sheer statistical incidence of kidney stones is actually an escalating modern threat.
Is it getting worse?
Yes. Large population surveys in the U.S. estimate that roughly 1 in 11 people will experience a kidney stone in their lifetime. And those rates are steadily climbing in both men and women, driven heavily by rising obesity and ultra-processed modern dietary patterns.
And it's not just our internal diet changing, right? It's the external environment itself. I was looking at the recent climate health research led by Gregory Tajian regarding a concept known as the kidney stone belt.
Yes, the kidney stone belt. Epidemiologists have long recognized this distinct geographic belt stretching across the hot, humid, southeastern United States.
Because of the heat.
Exactly. The mechanism is straightforward. The hotter the climate, the higher the rates of insensible water loss, meaning sweating. Chronic low-grade sweating leads to chronic low-grade dehydration.
And that drops the fluid volume in the kidney.
Which spikes the urine concentration, leading directly back to that supersaturation spark we discussed at the beginning.
But the Tajian research points out that with global climate change and steadily rising ambient temperatures, this phenomenon isn't going to stay confined to the southeast. They project that rising global temperatures are going to meaningfully expand the geographic reach of that kidney stone belt northward and westward in the coming decades.
It's a huge public health concern.
Right. A disease that was plaguing Egyptian mummies 4,800 years ago is now a major focal point in modern climate health modeling.
It is a striking, tangible intersection of human microscopic pathophysiology and macroplanetary climate science. It shows that our internal chemical homeostasis is intimately, physically tethered to the temperature of our external environment.
So what does this all mean? If you're a curious learner listening to this, trying to wrap your head around the immense amount of biology and history we've covered, there are really 5 core takeaways to remember. First, supersaturation is the universal spark.
Right. Regardless of the stone type, it all begins because the waste products exceeded the water's physical capacity to keep them dissolved.
Second, for the most common stones, they aren't just floating around freely. They actively anchor to Randall's plaques on the kidney wall.
The origin point.
Exactly. Third, the stone itself isn't the source of the agony pain equals obstruction. Renal colic only begins when that stone wedges into the ureter and causes a pressure cooker backup,
Which causes the swelling and the spasms.
Fourth, intuition can be a trap. Lowering dietary calcium is actually dangerous for most calcium stone formers because that calcium is desperately needed in your gut to act as a sponge for oxalate.
Do not cut your calcium.
Yes, keep the sponge. And finally, the chemical composition dictates the cure. You simply cannot treat a genetic cystine stone, a bacterially infected struvite stone, and a metabolic uric acid stone with the same generic dietary advice.
You have to identify and treat the underlying physiological mechanism, not just react to the symptom of the blockage.
Absolutely. And I want to leave you with one final, brand new thought to ponder, building off the physics of how these stones form. We just discussed how our external environment on Earth dictates our internal chemistry. But what happens when we leave this environment entirely?
Oh, the space travel angle.
Yes. Consider the future of human space travel. We know that in the zero-gravity environment of space, astronauts suffer from rapid bone density loss, right? Which dumps massive amounts of excess calcium straight into their bloodstream and kidneys.
A huge surge in the solute load.
Exactly. Now combine that with the chronic dehydration of living on a spacecraft. If zero gravity is the perfect biological recipe for supersaturation, are microscopic kidney stones destined to be the silent, excruciating barrier that keeps humans from successfully establishing a colony on Mars?
It's a very real hurdle for aerospace medicine.
It's wild to think about. Definitely something to think about the next time you pour yourself a glass of water. Thanks for joining us on this deep dive.